हेलो.
Yes, ma'am. मैंने अभी like किया है ना. Like now the stream is live.
Okay, so I should start, right?
Yes, ma'am.
Very good evening. Myself, I'm Dr. Ramyashri. I teach obstetrics and gynecology. So we have been discussing obstetrics and gynecology MCQs in past few days. So we'll be continuing with that same series. So we'll start with the MCQ discussion now, and we will be doing some of the gynec MCQs today in a continuation of the same this one. So I know you've been asking me to send the PDF. I'll be sending. So as I have some more questions in this PDF, I didn't send. So once I finish the entire PDF, I'll be sending all the questions at once to all of you. So today I'll send because I know you have the exam in another week, I guess, right? December 4th. Right. So let's start with the first question. Test used to detect genetic abnormality in embryo before transferring it to the uterus in IVF is amniocentesis, CVS, polar body biopsy, all of the above. So can we do that? Can we detect the genetic abnormality before transferring? Can we detect the genetic abnormality in the embryo before transferring it to the uterus? Yes, we can detect the genetic abnormality in the embryo before transferring into the uterus. So especially patients with recurrent pregnancy loss and known carriers of diseases or known the parents are known having the disease, right? And there is pregnancy again and again with an abnormal baby. You can do this PGD. You can do this detecting those genetic abnormality in the embryo and then transferring into the fetus. So the different procedures we have for that is, so what do you think, what should be the answer here? Amniocentesis chorionic villus sampling also helps you in finding the genetic abnormalities, but amniocentesis and chorionic villus sampling is done after the embryo is grown, right? So at what gestational age do we do amniocentesis? At what gestational age we do amniocentesis? Yes, Sai, Taruni. Amniocentesis is done around 15 to 20 weeks. Whereas chorionic villus sampling is done between 11 to 10 to 13 weeks. Polar body biopsy is done in the embryo before transferring into the uterus. Polar body biopsy is done on the embryo before transferring it to the uterus. Okay, so let's see that what are the, so this is called as peri-implantation. You have two things here. You have peri-implantation genetic screening and you have peri-implantation genetic diagnosis. Peri-implantation genetic screening is screening the embryos to ensure that all the 23 pairs of chromosomes are present and there is no aneuploidy. So it is a generalized screening of all the 23 pairs of chromosomes. That is called as peri-implantation genetic screening. Peri-implantation genetic diagnosis means you take the embryo and try to diagnose a known genetic disorder which any of the parent is having. So if you're trying to search for a particular disease, then it is called as peri-implantation genetic diagnosis. If you're trying to screen all the chromosomes for the aneuploidies, you call it as peri-implantation genetic screening, right? Diagnosis means certain diagnosis, screening is everything. So once you screen or diagnose, once you know that this embryo is perfectly fine, you put it into the uterine cavity. Okay. So you do the blastocyst transfer on day 5. So you have three ways for screening or diagnosis. That is, you can either take polar body and do the biopsy. But the problem with polar body biopsy is you're going to get the genetic material only from the mother. Or you can do trophoectoderm biopsy. That is the outer layer, you are taking some cells. Or you can do blastomere biopsy. So you have polar body biopsy, you have trophoectoderm biopsy and blastomere biopsy. Commonly used method is blastomere biopsy. Next, how to see if the pessary which is inserted, how to see if pessary is adequately inserted or not. Patient feels discomfort, does not come out during voiding. After Valsalva, pessary doesn't come out. 1 finger gap between vagina and the ring. Yes, what should be the answer for this? Patient feels discomfort, does not come out during voiding. After Valsalva, pessary don't come out. 1 finger gap between vagina and the ring. We'll see some points regarding the pessary. Okay. We actually have different types of pessary. This pessary which you're seeing here is called as the ring pessary. Which we use for prolapse, genital prolapse. Number 1 MCQ. So the different MCQs pertaining to the ring pessary are: how do you determine the size of the pessary? How do you identify what should be the size of the pessary which you are inserting? From the lower border of pubic symphysis to posterior fornix, the distance from the lower border of pubic symphysis to posterior fornix is equal to the diameter of the pessary with which you have to insert. Okay. So the distance between lower border of pubic symphysis to posterior fornix is equal to the diameter of the pessary. Okay. Now, next point is that how do you know that you have inserted adequate size? When you insert the pessary, you ask the patient to cough or laugh or strain. If the pessary doesn't fall, it means it's correct size. And second thing is that when you insert a large size pessary, it can compress the urethra. When you insert a large size pessary, it can compress the urethra. And when it compresses the urethra, it can lead to retention of urine. When it compresses the urethra, it can lead to retention of urine. Okay. If the patient doesn't have any of these two, it means you have inserted a correct size. If the patient doesn't have any of these two, it means that you have inserted a correct size. So how to see if pessary is adequately inserted or not? Patient feels discomfort. No. Does not come out during voiding. No. After Valsalva, pessary doesn't come out. So the answer here is C. So after the Valsalva also, if pessary doesn't come out, it means you have inserted a correct size. Second thing is that patient should be able to void patient able to void post pessary insertion. Patient able to avoid post pessary insertion is the another way telling that we have inserted an adequate size of pessary. Okay. So what are the indications where you have to insert the pessary? There are 3 indications pertaining to pregnancy and there are 3 indications pertaining to the surgery. So the 3 indications pertaining to pregnancy are a young woman who is planning a pregnancy, but she should have only grade 1 or grade 2 prolapse. It's not grade 3, grade 4 cannot be handled by a pessary. So young woman planning for a pregnancy with grade 1 or grade 2 prolapse during early pregnancy up to 18 weeks and during puerperium. Before surgeries, a woman who is unfit for surgery, in case of a woman who refuses for surgery, and for temporary use while you're cleaning the infection and decubitus ulcer. Okay, so 3 things: before surgery, when there is a decubitus ulcer, a woman who is unfit for surgery, and a woman who refuses for surgery. Okay, so those are the indications. Those are the indications for the pessary. What are the contraindications for, what are the limitations of pessary? The limitations is it is never curative. It's just palliative. You have to change the pessary every 3 months. You have to change the pessary every 3 months. This can also be asked as an MCQ. So you have to change the pessary every 3 months. It can cause infection, that is vaginitis. It can cause dyspareunia, painful coitus, right? And a forgotten pessary can lead to ulcer or carcinoma vagina and vesicovaginal fistula rare. It does not cure stress incontinence. It does not cure stress incontinence. There are different type of pessaries for curing the stress incontinence. Fimbrectomy is also known as Uchida procedure, Kroner's procedure, Irving's procedure, Pomeroy procedure. Fimbrectomy is also known as Kroner's procedure. It's called Kroner's fimbrectomy. All these methods which I have written here are the methods of mini laparotomy. Most common method of mini laparotomy is Pomeroy, modified Pomeroy method. Right? So these are the pictures of the different mini laparotomy procedures. So this is the Kroner's fimbrectomy where you're just removing the fimbria, but you have the entire length of the tube still intact. So this one has very high failure rate. Kroner's fimbrectomy has very highest failure rate among all mini laparotomy methods. Uchida. How does Uchida will be present? Uchida, remember it as bichda. Bichda means separated. Uchida, bichda. Both the ends of tubes will be bichda. So one end of the tube will be buried into the myometrium. Other end of the tube will be facing the peritoneum. So obviously both the ends are, one is this side, one is this side. So Uchida, bichda. So Uchida has least failure rate. They didn't observe any failure rate till now in 19,000 cases also. So Uchida has least failure rate. Now many students ask me, when Uchida has least failure rate, why not Uchida be considered as the what do you say, procedure of choice for mini laparotomy? It is not very easy to bury the fallopian tube into myometrium. It can bleed. So the procedure has least failure rate, but it is difficult. Not very difficult, but Pomeroy is comparatively simpler than Uchida. That's why Pomeroy is the one which is done. See, in Pomeroy, what we do in Pomeroy is we make a loop of the tube and we tie at the base of the loop and we cut this loop. We make a loop of tube and we tie at the base and we cut this loop. So that is called as pomeroy, right? Next, parkland. Parkland may you remove middle piece and you leave the two edges. Parkland may you leave the middle piece and you tie at the both edges. Madlanders, you make a loop, cut the loop, and you crush at the base. He's mad, that's why he's crushing at the base. Madlander also has good amount of failure rate. Okay. So if I have to grade about the methods and their failure rates, Uchida has least to highest. I'll write least to highest. Least failure rate is Uchida. Followed by we have Irving. Followed by we have Pomeroy. Pomeroy, 1 in 300 to 400 cases. So it's around 0.2 to 0.2 per 100 woman years. Parkland, Madlander, and Kroners. Right? So this is the order of the tubectomy. This is the order of the failure rates according to the failure rates. Laparoscopic sterilization also has your clips and rings have the failure rate in a range of 0.2 to 0.5 per 100 women years. As anyway I'm speaking about this tubal sterilization, I'll ask you some more questions I want you people to answer. Okay. What should be the timing of sterilization? These are very, very, very important. Timing of IUCD insertion, timing of sterilization, very important. Should be on your tongue tips. Right, let's start. Sharath or Taruna, Mukesh, any one of you can tell. What should be the timing of sterilization? For mini laparotomy, you can do concurrent with cesarean section. Matlab along with cesarean section, right? Next, you can also do it. You can also do it post delivery within 1 week. Interval, that is after 6 weeks. And you can do it post first and second trimester abortions. Whereas laparoscopic tubal sterilization, is done only. You can't do laparoscopic sterilization concurrent with cesarean section or post-delivery or second trimester abortion. You do laparoscopic sterilization only interval, that is after 6 weeks of delivery. Or you can do post first trimester abortions. Okay, laparoscopic sterilization can be done interval or post first trimester abortion. You should not do laparoscopic sterilization post second trimester abortion and post delivery, that is within 1 week and with concurrent with cesarean section. Why you should not do concurrent with cesarean section or post delivery or post second trimester abortions? Because in all these cases the uterus is up till umbilicus. When uterus is up till umbilicus, what is the point of keeping a laparoscopy? You can't. So whenever you have any mass up to 20 weeks, you should never do laparoscopy. Right? Okay, let's see the next question now. A healthy 35-year-old primigravida is referred to the antenatal clinic because the fetus is thought to be small for dates. Matlab IUGR, small for dates at 38 weeks of gestation. She had a dating scan at 9 weeks and a normal anomaly scan at 22 weeks. Why are they precisely telling that she has a dating scan, she has an anomaly scan and all? Because these patients, most of the time, the reason for small for dates and large for dates is wrong dates. Small IUGR and macrosomia is mainly because of your wrong dates. So that's why she's telling precisely that she has a dating scan. Whenever you have a scan at the early pregnancy in the first trimester and that confirms your EDD, it is an accurate dating. So that's why she had a dating scan, means her dates are perfectly normal. And supporting that, she also has an anomaly scan at 22 weeks, suggesting that her dates are very appropriate. Ultrasound scan shows a cephalic presentation. Abdominal and head circumference are below third centile with reduced amniotic fluid volumes. Below third centile with reduced amniotic fluid volume and reduced umbilical artery end diastolic frequencies. And reduced umbilical artery end diastolic frequency. There is a good fetal movements and CTG is normal. The cervix is 2 centimeters long, posterior and closed. How will you manage? So whenever we have a case with IUGR, it is very obvious that you will have the AC and HCR both reduced here, suggesting that the ponderal index would be same. So this looks like more case of symmetrical IUGR, because you have two types of IUGR, symmetrical IUGR, asymmetrical IUGR. Symmetrical IUGR is when the trauma to the fetus is at an early gestational age and they traumatize both the growth of the cell as well as the number of cells increasing. So it affects both the hyperplasia and hypertrophy of the cells. So as the hyperplasia and hypertrophy of the cells both is affected, hyperplasia as well as hypertrophy of cell both are affected. So abdominal circumference decreases, head circumference decreases. Whereas in asymmetrical IUGR, it is usually an insult to the fetus in third trimester. By third trimester, already the hyperplasia, the number of cells which have to be formed is over. So hyperplasia is over. Only the cell size is increasing. That cell size is not going to happen. So hypertrophy of the cell is what is affected in the asymmetrical IUGR. And by then, as the hyperplasia is over, the brain development would have happened. So it's a brain sparing. It's a brain sparing. So head circumference will be normal, but abdominal circumference will be decreased. Head circumference will be normal for them, but abdominal circumference will be decreased. As such, which has a good prognosis? Symmetrical IUGR has bad prognosis, whereas asymmetrical IUGR has a better prognosis. Because brain is paired here, right? And how do we come to know that we are dealing with the IUGR is by symphysiofundal height. In symphysiofundal height, you will see the decrease in the fundal height. Apart from that, by AC and HC circumference, ratios of AC and HC, and by umbilical artery Doppler. Please remember, see, all these are very, very, very important points. To know how is the blood supply to the fetus. To know how is the blood supply to fetus, the artery which should be examined is umbilical artery. Umbilical artery Doppler will tell us how is the blood supply to the fetus. Next, to know how is the blood supply, to assess the fetal anemia. Assess fetal anemia. What is the artery which you have to check? To assess the fetal anemia, the artery which has to be monitored is middle cerebral artery. To assess the blood supply to the fetus, it is the umbilical artery. To assess the fetal anemia, it is the middle cerebral artery. Okay. To assess the blood flow to the uterus is uterine artery, the indicator of preeclampsia, right? Now here, she's having AC decrease, HC decrease, and they're also having oligohydramnios. They're also having oligohydramnios. That's expected. Whenever you have IUGR, because of the decreased blood flow, brain sparing again, there will be decreased blood flow to the kidneys and GFR decreases and urine output will decrease. Coming to the umbilical artery and diastolic flow. So as I told you, the blood flow to the fetus is assessed by the umbilical artery Doppler. Normally, in umbilical artery, you have systole and diastole. Systole and a diastole. Systole and a diastole. So blood will be going to the fetus even during, blood obviously is going to the fetus during a systole. Blood also goes to the fetus during a diastole. It's not blood is going to the fetus during systole and diastole, it is coming back to us. No, blood goes both during systole and diastole, right? But whenever there is an umbilical artery vasoconstriction starting, blood goes with ease during a systole, but blood goes with difficulty during a diastole. So first abnormality, what you'll see is reduced diastolic flow. So you're having a flow, but it is reduced. And whenever you have, how do you measure this reduced diastolic flow? It is by systole by diastole ratio. Reduced diastolic flow is expressed as systole by diastole ratio. Reduced diastolic flow में when S by D ratio is more than 3, it means it's a reduced diastolic flow. Whenever you have a patient at reduced diastolic flow, deliver them by 37 weeks. Don't prolong their pregnancy beyond 37 weeks. Not worth, right? So deliver by 37 weeks. Equal to or more than 37 weeks. If you have absent diastolic flow, that means blood is going to the fetus during systole, but blood is not going during the diastole. Then we call it as absent diastolic flow. And when you have absent diastolic flow, deliver them by equal to or more than by 34 weeks. Third is reverse diastolic flow. Reverse diastolic flow is blood is going to the fetus during systole, blood is coming back during a diastole. That's very dangerous. So reverse diastolic flow, you have to do immediate delivery. Reverse diastolic flow, you have to do immediate delivery as there is a impending sign of death in next 24 hours. So the cervix is 2 centimeters long, posterior and closed. How will you manage? You will manage it by, so as she is 38 weeks, she is reduced diastolic flow. So reduced diastolic flow, you have to deliver them by 37 weeks. And she has gone beyond 37 weeks. So there is no point in waiting on her. So better go for induction of labor. Understood? As she has crossed 37 weeks and she is having reduced diastolic flow, no point in waiting. You can just do induction of labor and deliver her. Okay. Next question. A healthy 23-year-old attends the antenatal clinic at 20 weeks of gestation. Her investigation undertaken at 16 weeks shows that hemoglobin is 8.5 gram per deciliter. MCV 80 femtoliters with reduced mean cell hemoglobin. What is the next investigation which you want to do? Okay, I have B as the answer. Very good, excellent. So whenever you have, see what is MCV showing, she is definitely anemic. She is definitely anemic. And MCV is showing 80 femtoliters. 80 femtoliters means microscopic. Microcytic hypochromic anemia with reduced mean cell hemoglobin. It means she's also having reduced microcytic hypochromic. It's microcytic hypochromic anemia. So what is the next investigation which you want to do? There's no point in doing, what are the two differential diagnoses which we have whenever you have microcytic hypochromic anemia? The two differential diagnoses of microscopic hemolytic hypochromic anemia are serum ferritin. Sorry, the two differential diagnoses are iron deficiency anemia and thalassemia. Iron deficiency anemia and thalassemia, right? How can I differentiate between this iron deficiency and thalassemia? It is by serum ferritin. Why? Because serum ferritin is the most sensitive marker for iron deficiency anemia and it is the earliest to decrease. It's the most sensitive and it is the earliest to decrease. Right. So if serum ferritin is less, then it is iron deficiency anemia. If serum ferritin is normal to increase, it is thalassemia. Serum ferritin is normal to increase, it is thalassemia. Other way of differentiating iron deficiency and thalassemia, anything else, you know? Yes, you have red cell distribution width, Menzer's index. Those are all other ways, okay? How do you confirm thalassemia? Confirmation of thalassemia is by high performance liquid chromatography. High performance liquid chromatography. When you do high performance liquid chromatography, you will see HbA2 levels increased. When you do high performance liquid chromatography, you will see HbA2 increased. In iron deficiency anemia, what will you see is the serum ferritin decreases. Serum iron decreases, but those with starting with T, that is serum transferrin and total iron binding capacity, both will increase. Serum transferrin and TIBC both will increase. Okay. Right. So that's about the iron deficiency anemia. Next question. What should be the management for this patient? How do you want to manage this patient? Second trimester, 20 weeks or 16 to 20 weeks, second trimester with anemia. Moderate anemia. Second trimester with moderate anemia. How do you want to manage such patient? Do you want to give them injectables or do you want to give oral? So as you have long time and she's just 20 weeks, as she's having long time and she's just 20 weeks and it's just moderate anemia. See, you have to start parenteral only for those patients who have gone beyond 30 weeks. Last 10 weeks may, if with anemia, go with parenteral. But before 30 weeks with mild to moderate anemia, go with oral therapy. But you have to increase the dose of iron. So you can give ferrous sulfate double dose, 200 milligrams 100 milligrams BD. We normally give 100 milligrams of elemental iron OD, right? So you can give 100 milligrams of elemental iron BD, or provided if they're following this Anemia Mukta Bharat, 60 milligrams of elemental iron BD. So you have to increase the dose of the oral therapy. Very good, Akansha. So better go with oral therapy because she is less than 30 weeks. So any mild to moderate anemia before 30 weeks, go with oral therapy. Any mild to moderate anemia after 30 weeks, you can go for parenteral. So there is no indication for parenteral here. You can just do it oral therapy to them. How do you diagnose menopause? Estradiol less than 20 picogram per ml, progesterone less than 40 nanogram per deciliter, FSH less than 40, LH less than 40, less than 20. So menopause is cessation of menstruation for more than 1 year. Menopause is cessation of menstruation for more than 1 year, right? In menopause, you have complete follicular depletion. So you have no estrogen. Estrogen is nil. So they have decreased estrogen. Excellent. So estradiol will be less than 20 picogram per ml is appropriate statement. And as the estrogen is low, there is no negative feedback on FSH. So you'll have increased levels of FSH. So they have increased levels of FSH and LH. Both FSH and LH should be more than 40 international units per liter. So the diagnostic criteria for menopause is cessation of menstruation, appearance of menopausal symptoms like hot flushes on 2 occasions 1 month apart, suggesting that there is a vasomotor symptoms. Vaginal cytology shows 100-0-0. So what is this 100-0-0? Parabasal and basal cells are 100. Intermediate and superficial cells are 0 and 0. Superficial cells are estrogen dependent. They're pink and polygonal. Intermediate cells are progesterone dependent. They're blue and polygonal. Parabasal and basal are under the no hormonal influence and they are round to oval. Those are the cells which we increase. So parabasal and basal cells will increase, whereas intermediate and superficial cells are completely zero. Completely zero. Serum estradiol should be less than 20 picogram per ml. Serum FSH and LH should be more than 40 milli international units per ml or 40 international units per liter. Apart from that, menopause, other points which are very important are, for menopause, the treatment of choice is hormone replacement therapy with estrogen and progesterone. Whenever a patient has uterus, give both estrogen and progesterone. When a patient doesn't have uterus, you can give only estrogen, right? And what are the indications to start them on HRT? Osteoporosis, vasomotor symptoms, urogenital atrophy. You should not start HRT for prevention of cardiac diseases. You should not start HRT for prevention of cardiac diseases. A 23-year-old female came with the complaints of 4 months of amenorrhea. The FSH and LH were elevated above the normal value. Thyroid function tests were normal. What is the next step in management? Give progesterone and stop after 10 days for withdrawal bleeding. Check USG for PCOS. Estimate serum estradiol values. Do a UPT. Most of the time, students always answer do UPT, right? Because according to all of you, whenever a patient is having amenorrhea, the first thing to rule out is pregnancy, because the most common physiological cause of pregnancy is amenorrhea. The most common physiological cause of amenorrhea is pregnancy. So any patient with amenorrhea, you always do, especially secondary amenorrhea, you always do the UPT. I agree with you. But here, I don't require to do a UPT, because it is not the first step they are doing. They already came with some investigations, which is telling that FSH and LH are elevated. What are the conditions where you'll have FSH and LH elevated? What are the conditions which you'll have FSH and LH elevated? So FSH and LH are elevated whenever your end organ is not working. Whenever the end organ is not working, that is the ovary is not working. So it is something related to the ovary. So probably ovarian failure. How can I confirm the ovarian failure? FSH and LH will be more than 40, but when you measure the serum estrogen, it will be less than 20 picogram per ml. So same way as the FSH and LH are elevated. Yes, excellent, Akansha. So this is a case of premature menopause. This is a case of premature menopause. So as the FSH and LH are elevated, what will you do? You estimate the serum estradiol values. You estimate the serum estradiol value, which will show you decreased, which will show it to be decreased. Okay. The most common cause of secondary amenorrhea is pregnancy, physiological. Most common pathological cause of secondary amenorrhea is PCOS. The most common cause of primary amenorrhea is gonadal dysgenesis. Second most common is Turner's. Third, MRKH, followed by we have the AIS. Next question. A 30-year-old woman with complaints of dysmenorrhea, dyspareunia, and chronic pelvic pain undergoes hysterectomy. From the cut section of the hysterectomy specimen below, identify the condition. Yes, what is your answer? So this is a globular uniformly enlarged uterus. It is not leiomyoma. Because leiomyoma mein uterus will be irregularly enlarged and you will have bossylated appearance. So this is not a leiomyoma. Excellent, Rakshita Narayan. So it cannot be a fibroid also, because fibroid and leiomyoma are same. Endometriosis is presence of functioning endometrium outside the uterus. This is not a problem outside the uterus. It is per se problem of the uterus itself. So this uniformly enlarged uterus with multiple endometriotic cysts are nothing but the adenomyosis. Okay. So it is adenomyosis. How am I telling this is an adenomyosis? Because you're having a uniformly enlarged uterus. You have a uniformly enlarged uterus with multiple cysts. Can you see this cyst? Subendometriotic, subendometriotic myometrial cysts. So in the myometrial, you're having cysts. No, that's very, very classical. So this uterus will be tender. That's called Halban's sign. Now let's speak few words regarding the adenomyosis. Okay, this is a NEET 2018 question. Adenomyosis is presence of functioning endometrium into myometrium. Adenomyosis is presence of functioning endometrium into myometrium. Okay. Usually it is seen in age group of 35 to 40 years. Clinical picture, they'll have dysmenorrhea, secondary dysmenorrhea, and heavy menstrual bleeding. On examination, uterus will be uniformly enlarged and globular. It will be uniformly enlarged and globular, and it will be tender. The tender uterus is called as Halban's sign. Tender uterus is called as Halban's sign. Okay, and investigation of first line investigation is TVS, whereas investigation of choice is MRI. So on TVS, you will see heterogeneous hyperechoic cysts in the myometrium, and that will appear as salt and pepper appearance or Venetian blind appearance. That will appear as salt and pepper appearance or Venetian blind appearance. Usually they can grow up to 12-week size. Usually they can grow up to 12-week size. Okay. Treatment, first line, give them progesterones. First line, LNG-IUS. Alternate to this is GnRH analogs. If they're not responding to medical management, then you have to go for hysterectomy. So that's important points pertaining to the adenomyosis. Those are the important points pertaining to the adenomyosis. Adenomyosis is very frequently confused with fibroid. Next question. A 17-year-old female presents with delayed puberty. Her mother reports her daughter has never menstruated. On examination, patient is 4 feet 11 inches in tall. What is the following test? Which of the following test is most likely to confirm the diagnosis? Karyotype, follicular stimulating hormone, luteinizing hormone, cranial MRI. So, she's a case of primary delayed puberty, 4 feet 11 inches. Matlab height is normal. Which of the following tests is most likely to confirm the diagnosis? Karyotype, FSH, LH, MRI. Any case of primary amenorrhea, what is the investigation which helps you to go towards your appropriate disease? Excellent, Akansha. So karyotype is the best investigation where we can differentiate and understand which type of amenorrhea we are dealing with, right? So if it is 46XX, the differential 46XX with primary amenorrhea, MRKH, Mullerian-Rokitansky-Kushner-Hauser syndrome or Mullerian agenesis. If it is 46XY, if it is 46XY, you have two differential diagnoses, Swayers and AIS. Swayers and AIS. Okay. And if it is 45XO, then it is Turner's. Then it is Turner's. Okay. And how do you differentiate between these syndromes also? I'll tell you one simple way. In your MCQs, if you have something like this, you go with how to MCQs mein what in amenorrhea MCQs, what you have to observe, I'll tell you. Check for the uterus. If uterus is present, check for the secondary sexual characteristics. Secondary sexual characteristics are absent. Uterus is present, but secondary sexual characteristics are absent. And karyotype is 45XO. It is Turner's. And uterus present, secondary sexual characteristics absent. And if it is 46XY, Swayers, which is a SRY gene mutation. Okay. And second set is uterus present, secondary sexual characteristics absent. XX. Uterus present, secondary sexual, uterus absent. Uterus absent. Secondary sexual characteristics present. 46XX, it is MRKH. And if it is 46XY, it is AIS or testicular feminization syndrome. If it is it is AIS or testicular feminization syndrome. And AIS or testicular feminization syndrome, it is a testosterone receptor defect. So axillary and pubic hair will be absent. Axillary and pubic hair is absent. Okay. So that is regarding the amenorrhea syndromes. One last question we'll do for today. Postcoital test detects all of the following except fallopian tube blocked, cervical factor abnormality, sperm count, sperm abnormality. So postcoital test is also called as Sims-Herner test. Sims-Herner test. This test, what we do is, it is mainly used to check the cervical mucus hostility and the number of sperms also it can tell. So couple is advised to have an intercourse close to the ovulation, preferably in the early morning hours, right? And then the woman should report to the clinic within 2 hours. Once she reports to the clinic within 2 hours, you aspirate that mucus and spread it on the glass slide. When you spread it on the glass slide, you take, normally you should see 10 to 50 motile sperms per high power field in the cervical mucus. If you are able to see 10 to 50 motile sperms per high power field in the cervical mucus, means cervical mucus is permeable to sperms and they are also having good amount of sperms and motility is fine. Cervical mucus also is examined for its quantity, furning pattern, and viscosity. Right. So advantage of this test is that cervical mucus can be studied simultaneously for estrogenic effect. So the cervical mucus will be thin, copious, stretches between two fingers, and it will be furning will be present before ovulation. So that also you can examine here, right? So this postcoital test actually is now an outdated test, but what are all the advantages of this postcoital test are? So it cannot detect fallopian tube block. It cannot detect fallopian tube block, but it can detect cervical factor abnormality. It can detect sperm count and it can detect sperm abnormality. So these are all the important points pertaining to the postcoital test. Okay. So those were the MCQs for today. I think we had a great session where we discussed some of the important MCQs. Tomorrow, tomorrow, tomorrow we will. Okay, Nishama. Tomorrow we'll discuss oncology. Tomorrow 7 p.m. I'll be again coming back, and tomorrow we'll be discussing the oncology MCQs. So more than oncology MCQs, I think we can discuss oncology as a last minute revision points. You know, all the important points with each cancer. So I'll try to include the cervical cancer, a quick go through of the cervical cancer, ovarian cancer. Like, you know, it will be revision for you because oncology is something which scares you. So I'll do a quick revision of the oncology tomorrow. Okay. Thank you guys. All the best. Keep studying. See you again tomorrow at 7 p.m.